Maybe some of y'all are going to watch this recording. Maybe you attended SNRS this week. I know we've got some things going on. This is actually our first meeting of 2022. Our last meeting was canceled, so I'm glad everybody could attend. And I want to introduce AnnMarie Walton. She is just a hop, skip, and a jump for me in Greenville, but she's at Duke University School of Nursing. And she's an assistant professor there, and she's come today to speak to us about occupational exposures to carcinogens. I think I reached out to AnnMarie to talk to her about the nurse climate challenge, I believe, and then we talked more about her coming to speak to this group today. So we're excited to have her. But she's done work with both with pesticides and Latino farm workers in North Carolina, as well as occupational exposures with healthcare workers, nurses, and environmental service workers. So we're excited to hear about her research and her policy involvement.
Thank you so much, Liz. It's really a pleasure to be here with you all today. And I'm going to tell you a little bit about my entire program of research. So just a little bit about a variety of studies and sort of how I frame this work. So I'll begin by sharing a little more about myself and my background so that this makes sense to you in context. I have not always been a nurse. I got a bachelor's in community health education with a minor in Spanish language and literature from the University of Maryland, and there became a certified health education specialist. I came down to the South and never left for an MPH at the Gilling School of Global Public Health at UNC. And while I was working on my MPH, entered the US Public Health Service as an ensign, intending to do lifetime career service. It's the only unarmed branch of the military, and was stationed in Shiprock, New Mexico while I was working on my MPH. And it was there that I had my mind really blown about nursing. I come from a long line of nurses. My mother's a nurse, my grandmother's a nurse, but I knew only hospital-based nursing. And what I saw out on the Navajo reservation was a very different kind of public health nursing and population health nursing that was really exciting to me. And so I finished that MPH and then immediately enrolled in an ABSN program also at UNC. I came out at a time of a great nursing shortage. And so the deal was, if we made a contract with UNC hospitals, they would pay for our degree. So I contracted for 18 months and I ended up staying for 13 years in inpatient hematology oncology, where I had a variety of roles from clinical nurse 1 to clinical nurse 4, and then eventually created the first nurse manager job share in the state of North Carolina. While I was working in inpatient hematology oncology, I took care of a lot of young Latino men because of my Spanish language skills, who had the same subtype of leukemia, which was Philadelphia chromosome positive ALL. And I was really interested in what it was from a public health perspective that was causing these otherwise really healthy young men to get leukemia with no family histories of cancer, that kind of thing, and heard the commonality among them. And anyone who's worked hem-onc knows these patients stay a really long time, was their work in the fields. And so when I decided to go back for a PhD in nursing with an oncology cohort at the University of Utah, I focused my dissertation on understanding the pesticide protective behaviors of Latino migrant and seasonal farm workers here in North Carolina. Then I was also here in North Carolina at UNC for a postdoc, which was focused on interventions. And I've been faculty at Duke since 2017, where I teach population health and policy. So enough about my background, but hopefully it helps contextualize why my program of research is what it is, and how it pulls my various educational training and background together. So this is a very simple framework, but I think this is the best way to kind of pictorially show how I see my research being related. And that's that I'm really interested in these bidirectional relationships between exposures and protective behavior, as well as exposures and policy, and protective behavior and policy. But probably most important is that at the center are populations of what I would call hardly reached workers. And I coming from the UNC School of Public Health, really don't like the terminology of hard to reach workers, because there's nothing about these people that are hard to reach. We know exactly where they are. It's that, and it changes the onus of responsibility. We are not including them. We are not reaching them. And so I think here about farm workers, and I also think about EVS workers and nursing assistants, and I'll talk more about those populations in a little while. As I've done more and more work, my interests in policy have really kind of refined to administrative and engineering level controls, and I'll talk a little bit more about that as well. And protective behavior, as we know, is very individual, a very individual level way of controlling exposures to known hazards. So let me just give a little bit of background, because I'll start kind of from the beginning of my research career, which was with my dissertation. And for those of you who know less about pesticides, pesticides can have adverse health effects from nausea, vomiting, headache, dizziness, and skin rashes in the short term to chronic exposure concerns like damage to the nervous system, reproductive problems, and an increased risk of certain kinds of cancer. There is a policy called the Agricultural Worker Protection Standard, which mandates that pesticide protective behaviors be taught to field workers. So these are not people who are applying pesticides, but people who come into contact with them in the field. So more who we think of as a traditional farm worker, someone who might be picking tobacco or strawberries or sweet potatoes. And it used to be that they had to be taught these behaviors within 5 days in the field and then have those re-taught every 5 years. At the time, as I was finishing my dissertation, this changed to be annual training required as of 2017 and no grace period for that training. So you didn't have those first 5 days. You had to have that training before you ever went into the field. The Agricultural Worker Protection Standard includes training on the right clothing to wear, which is the long sleeve shirt, long pants, closed shoes, and socks, as well as mandated washing behaviors. So washing hands and face before eating, drinking, using the bathroom, smoking, and chewing gum or tobacco. So for my dissertation, I decided to look at the pesticide protective behaviors of Latino, migrant, and seasonal farm workers that were mandated to be taught in the worker protection standards. So those clothing behaviors and then those washing behaviors. And everything that I found in the literature was self-report from farm workers. And I think we can think of a lot of reasons why farm workers may not feel comfortable reporting exactly what it is that they do in the field. And so I also did an observational component of this study, and I'll talk a little bit more about the design in the next slide. But I spent 4 months in North Carolina tobacco fields with 72 farm workers, observing them, and then was able to compare what they self-reported and what they actually did in the field. The second aim was to identify their perceived barriers and strategies to counter barriers using the behaviors that were mandated to be taught. So what got in their way of washing, what made washing easier, what got in their way of wearing the protective clothing, and what made that easier. So the design for the dissertation was a descriptive multi-method study. I recruited 3 growers in 1 county in North Carolina. All of them had participated in the Certified Safe Farm program, which Liz is probably familiar with. And then neither the growers nor the farm workers that were involved in my study knew that I was specifically focused on pesticides. I had gone through some agromedicine training out of ECU. And so they knew that I was a nurse, and they knew that I was interested in agriculture and safety, and that I was interested in watching them while they worked. So I could have been looking at their mechanics or their lifting or any number of things. I collected data sequentially across the 3 farms. So that meant that even though they were all doing tobacco, there were different tasks being done in tobacco on those 3 fields when I was there. So the very last farm that I was at was doing barning and harvesting, whereas the first one was just putting the tobacco in the field. And then, as I mentioned, I observed these farm workers in the field anywhere between 6 and 12.5 hours each participant. And that was just based on weather and how long they worked that day and what was going on for them. And then I returned on Sunday evenings to wherever they were living, whether that was grower provided housing or housing in the community, and conducted some targeted interviews. I also asked those same questions that I asked of farm workers to the growers last, so that I could also get their perspective on things, but they wouldn't know exactly what I was asking the farm workers. And this is a picture of some of the farm workers that were in the study, as well as Liliana, who was the research assistant on my study and was a social work student at NC State at the time, whose parents were farm workers in that county. And so she was very familiar, not only language-wise, but culturally with this study. And she was with me on each of the Sunday nights. So this is a busy slide and probably pretty small, but the pieces that I want to highlight for you are the green and the red arrows. So we took the observed and reported responses for each of these behaviors. So for example, if we look at closed shoes, it's green. There were no significant differences between what people told us they did, which was to wear closed shoes all the time, and what they actually did. So that's green, that's good. People were wearing closed shoes in the field for the most part. The same is true in the wearing of long pants. Only one person did not wear long pants all of the time. And you see the same thing with the wearing closed shoes. Only one person did not wear closed shoes all of the time, but wore like a sandal with a sock, which definitely wouldn't be recommended. And then wearing of socks was more challenging. And we realized that right away, because people had on these really protective work boots and pants. You really couldn't see whether they had their socks on or not. But in any case, we believe that that was pretty close to what they were reporting, and that if they had on big work boots, they also had on socks. What was more concerning in terms of the wearing behaviors was the wearing of long sleeves. People over-reported wearing long sleeves compared to what was observed. And that's because when I was actually observing them, they would roll their sleeves up as the heat of the day got more significant. And then you're not really wearing a long sleeve shirt anymore if you've rolled it up over your elbows. Or the same thing would happen sometimes earlier in the morning after being in the morning dew and feeling wet. So you would roll those sleeves up. Most concerning, though, were these washing behaviors. And you can see statistically significant differences for all of them, that people grossly over-reported the washing of hands before eating and drinking, and the washing of their face before eating and drinking. In fact, I never saw the washing of face at all before eating and drinking. And the washing of hands was over-reported compared to what was done. So if you're interested, that's all I'll say about this study, but if you're interested to learn more about it, there were 3 papers as a result of the work, and then there was a fourth paper as well, which looked specifically at a tool called the Pesticide Risk Belief Inventory, and that was administered as well, and that's come out in the last year. But important to me is that I spent probably a year, the first year of my postdoc, going back to the community that had helped me to get this data and sharing the results with them. And so one of the groups that I went to talk to was the North Carolina Farm Worker Health Program. And they have 100 outreach sites across the state. And they employ outreach workers who do a lot of education with farm workers. And so when I went to present to them, it was to talk to them about how they do what we saw in terms of needing more washing in the field. And then they came and talked to me about how they were currently doing hand washing education and how they thought that it could be improved. So we were very fortunate in that they gave us funding to help them develop a hand washing educational toolkit. And so during my postdoc, we conducted focus groups and web-based surveys with farm worker health outreach workers to learn more about how they were doing hand washing education in the field. And then we created this toolkit, which contained pesticide residue activities using a fluorescent tracer. Some of you have probably heard of this. It's called GlowGerm. And then we created these one-on-one and group discussion questions and a trainer's guide, both in English and Spanish, that detailed the learning objectives, the supplies needed, and step-by-step instructions. We purchased enough for the North Carolina Farm Worker Health Program sites, and we wrote about this experience as well. We did the first set of trainings with the outreach workers, and then they created a train the trainer program where outreach workers were training new outreach workers who came into the program and keeping up the supplies. So naturally, as researchers, we want to know whether or not this toolkit makes a difference. And so our community partner led a user satisfaction survey with the outreach workers to see if they were appreciating use of the toolkit and how it was going for them. And then we were really interested to see if this reduced pesticides on hands, if being taught to do better hand washing in the field and the importance of hand washing and activities that were really specific to farm workers. So we created, I should have mentioned more about the activities. We created one activity with trace residue on a cell phone, because we saw farm workers handling their cell phone throughout the day with hands that were dirty with pesticides. We created one around fruit, because we saw very often that farm workers would eat fruit from the field that they simply just washed on or rubbed on clothing before eating. And then there's contamination on their hands as well as their clothing. And naturally they're ingesting that as well. So anyway, we wanted to see if training farm workers with this toolkit would really make a difference in terms of pesticide residue on their hands, and if washing hands really decreases what we could measure. So we received some small funding from the Southeast Center for Agricultural Health and Injury Prevention at the University of Kentucky. And in the fall of 2019, we started to do some hand wipe analysis. And the idea behind this was that once we knew that this was a measure that would work, then we could design a study where some people had received education this way, others had not received education this way, and we could look for the differences. So in the fall of 2019, we went back to some of these same farms that had participated in my dissertation work and had participants wipe the whole hand with a sponge moistened in alcohol. And I think I don't have a picture of the actual procedure, but had them do their hands at various times of the day before and after washing, just to kind of get a sense of what we could obtain in terms of pesticide residue. You'll see here in this picture, which is state van, that this was our data collection station in the field. And we learned very quickly just how challenging it is to do this kind of work in the field. So we learned, we didn't know this about alcohol, but it's very hard to pull up isopropanol and wet sponges with it in high heat. It pulls very slowly. The sponges could become contaminated due to wind and dust. If you've spent any time on a tobacco farm or any farm, you know how windy and dusty it can be. And then it just took us a ton of time to prepare the sponges in the field that the farm workers really didn't have, with us doing this at multiple time points in the day. So we came up with a better process with pre-moistened sponges, and things were far better by the end of this little pilot. Unfortunately, we don't have all of our data back. This went to a lab at NC State that closed during COVID. And since reopening, we've had some challenges getting all of our data processed, but this is just what some of the preliminary data looks like. This is a fungicide. And so we were able to see that we could detect this pesticide on the hands of farm workers, and we're still doing some of the analyses. So the next steps in this work are naturally to complete the measurement of the pesticides from those hand wipe samples that we already collected, and then to try to do the evaluation that we wanted to do about whether or not there is less pesticide residue on the hands of farm workers who have had this kind of training with the toolkit compared to those who have not. So I'll pause for a second and tell you that I'm going to talk about something totally different. I don't see this as a diverging path. I see it as sort of a parallel path. And in so many ways, the two kinds of research that I do inform each other. And that's really actually helpful to see outside of one domain and into another, and make some parallel realizations. So at the time that I was doing my dissertation work, I mentioned that I was working in inpatient hematology oncology, and I stepped down from a nurse manager position and worked per diem throughout my whole dissertation. But while I was working as a clinical nurse I was involved in this oncology clinical practice group, and we were charged with reviewing our policies. And so we were reviewing our policy on safe handling of hazardous drugs. And we worked very hard. It's a much longer story, but we worked very hard to make some changes within our hospital. So we didn't have great signage to tell us exactly who was receiving these antineoplastic drugs. We were using some chemotherapy rated gloves and some that were not chemotherapy rated. We didn't necessarily have all of the best ways to discard PPE that was contaminated with chemotherapy waste. And so we, as a team, for over the course of about a year, came to realize some changes that we needed to make in our hospital policy to handle these drugs safer as oncology nurses. And so I, knowing that I was headed back to school, I went back to school in 2011, began working on a manuscript about this and doing some local presentations. And so it was what they tell academics, right? Like, you know, get some experience with presentations and publications as you're going back to school. And what grew from that, I could not have imagined, but also really unfolded as I was doing this dissertation work at the University of Utah. So in 2013, I received an invitation to work on a state-based policy called North Carolina House Bill 644, which basically would mandate that hospitals and healthcare facilities provide PPE to their workers who were handling these antineoplastic and other hazardous drugs. So NIOSH, the National Institute for Occupational Health and Safety and Health, has a series of recommendations about PPE use, but these are not mandates. So hospitals don't necessarily have to comply. And so the person who invited me to help work on this policy had read this paper and said, oh, you clearly did some small p policy change within your institution. We're interested in some state-based big P policy change. Would you like to help? And at the time, I was pregnant with my second child. I was working on this dissertation. I wasn't administering these drugs myself. And I thought, surely I'm the wrong person for the job. But she said, no, come anyway. We really want to hear from you. And so what transpired was that I helped to get the support of two large nursing organizations in North Carolina behind this legislation, and really was an advocate for the passage of this law. And it passed in 2014. And then the North Carolina Nurses Association asked me to serve as the nursing representative to the Department of Labor for a year as this law was written into regulation. So exactly how would we do what it was that we had just passed? And I learned so much during that process and during that experience about policy. I also had the opportunity to give a national congressional briefing because we were starting to talk about this kind of policy at the national level and not just at the state level. And what happened for me, maybe it was because I was in a PhD program at the time, was that I had so many questions. I realized that in order to really make a difference in policy in this arena, there was a lot of missing data. And so it really shifted my research focus by being involved in this policy work. So this is the briefing. Let me give you a little bit of background here. So antineoplastic drugs, for those of you who are less familiar, you can think of them as chemotherapy, and they also, very similarly to pesticides, have both acute and chronic health conditions that are associated with them. Acutely, you can think about what patients who receive chemotherapy experience: skin rashes, allergic type reactions, hair loss, and nausea for even the people administering them who are exposed. And then what we're most concerned about are these adverse reproductive outcomes. We know that there's infertility and subfertility associated with these exposures, as well as congenital malformation and miscarriage. There's also an increased risk of certain kinds of cancer for healthcare workers who have long-term low-dose exposure to these agents. So in my postdoc, while I was doing that focus group research and trying to help with the toolkit that came out of the dissertation work, I really shifted my own focus to look at nursing assistants and their exposures to these drugs. I knew as an oncology nurse who had administered them that I had very standardized education and training, but that nursing assistants very often weren't even aware of who was receiving these drugs in the healthcare setting. I should also mention contextually that Ebola happened while I was in my PhD program, and the very first healthcare worker to get sick with Ebola was a nursing assistant who was exposed to the vomit of the patient. And so it really got my mind moving about nursing assistants and their exposures and their lack of standardized education and training, and their safety. So I conducted an exploratory multi-method study using observation, again, just like in my dissertation, as well as verbally questionnaires and interviews. And importantly, found out that nursing assistants who are hardly reached as well, not hard to reach, but hardly reached, were really willing to participate in research. They wanted to know what they were exposed to and they wanted to participate. We learned that there was room for improvement in the PPE that they used, especially when handling chemo-contaminated excreta. So they didn't use double gloves. They didn't use chemotherapy gowns very often. Their face shield use was low, but they did use these plastic back pads that we call chucks when they flushed the toilet. And we found that they had a lot of insights in how to improve their own training, their own education, and how to use more PPE in the workplace. So after my postdoc, I moved here to the Duke University School of Nursing, and my first internally funded pilot was to help me with the skills needed. Again, just like I needed to get hand wipe sampling so that I would know if future interventions were effective, I needed to know how to measure contamination, to know if any interventions that I did to minimize antineoplastic drug exposure would be effective. So my first pilot was just simply to try to describe the inpatient oncology surfaces that were most contaminated with antineoplastic drugs, and to characterize the PPE use in inpatient oncology and factors that influence its use. So in this study, which you can read more about in brief, we had an inpatient oncology and inpatient BMT unit. We had nursing staff take a survey. We sampled 2 rooms per unit where patients were receiving either cyclophosphamide or etoposide, which are 2 types of chemotherapy. And then we sampled shared areas where PPE use was not expected, and we did those areas twice. So here you're thinking about like your break room, your bathroom, your locker room, that kind of thing where staff would not be wearing PPE. For the survey, we used an adapted version of this PPE use and predictive factors survey. And here you can see a picture of our swabbing technique. I actually swabbed some bathrooms today, which I'll tell you about later. And then we did our analysis by liquid chromatography mass spec. So what we found was that in these 2 inpatient oncology units, 61% of surfaces that we tested were detectable and quantifiable for cyclophosphamide, and 30% were detectable and quantifiable for etoposide. Those levels are fairly low, and I wish I had more time so that I could talk to you about picograms and nanograms and milligrams and all of those things, but nanograms are really, really small. This is a very trace amount of contamination, but we're still concerned about it because for these known carcinogens, we can't say that there's a threshold at which genotoxic effects occur. Everything, NIOSH, OSHA, everything says as low as reasonably achievable. So we want this stuff in the environment at as low levels as is humanly possible. Most commercial testing kits will pick up things that 0.05 nanograms per centimeter squared or above. So if we had used a commercial testing kit, we would be looking here in this 6% and 12%. I guess here's my cursor, sorry, range for each of these drugs. But because we had a really sensitive technique and I didn't talk a lot about this, but we spent a year working within pharmacokinetics, pharmacodynamics lab here at Duke, setting up our equipment and machinery and kind of getting ready to go, we were able to detect levels down to picograms. And so we were able to detect even lower levels of quantification than a commercial testing kit would be able to. We found that within the patient rooms, and this was surprising to us, the most contaminated spot was the toilet. And these were not drug metabolites. This is straight drug. So this is not that's interesting. Also, we found the remote control was the second most contaminated spot in the patient rooms, and the floor below the IV pole. And that one kind of makes sense because you can think about nurses spiking and unspiking bags of chemotherapy, but the remote control, we all know from just our lay lives, is pretty gross. When we think about shared areas, what we found was that what was most contaminated were floors. And so here we're starting to think about, and we know this from the farm worker setting as well, that people are tracking this contamination around the unit. So maybe the original exposure happens in a patient's room, but then they go to the break room, then they go to the locker room, then they go sit down and eat lunch. And so when we test the floors in these shared areas, they're highly contaminated, again, highly at our levels of trace contamination, but frequently contaminated. Likewise, we saw contamination on the common phone, on the handle to the medication fridge. So areas where you would not be wearing PPE. I'll say just a couple words here about that second aim, which was to describe PPE use. People were pretty good about their PPE when it came to administering the drug, and then it kind of went down from there. So they were less good about PPE when they were handling empty chemotherapy bags, taking down the chemotherapy, and then kind of the worst actually when handling excreta, which seems counterintuitive. They were great about the gloves, but they didn't put on a whole chemo gown, which is actually what's recommended, or use any sort of face protection when flushing this chemotherapy. So we also did some exploratory, we wanted to use that PPE and protective factor survey, and we wanted to see if PPE use was related to any of these predictive factors. And we found that it's moderately associated with workplace safety climate, which if we think about a NIOSH kind of hierarchy of controls approach, is above the individual level of PPE, and it's above the level of an administrative control. Well, I guess really it is in the level of an administrative control. So something that is above the level of the individual, we also need to consider. I won't say too much more about that here in the interest of time. So what was most of interest to us was the levels of contamination on the toilet seats. We started thinking about patient and family education. We know that patients and families are taught to use 2 different bathrooms at home if they can, because of the risk of contamination from the excreta of the patient. But it also made us think a lot about nursing assistants and EVS workers and people whose job involves coming into contact with the excreta of patients. We also thought it was interesting, something was developed in the decade before this study was done called a closed system transfer device, which was meant to minimize aerosolization and vaporization of these drugs in the environment. And we asked these nurses if they were using a closed system transfer device, and many of them said that they were, but the reality was their hospital hadn't purchased it. So they didn't really even understand what this control was, and that was an engineering control. So again, if we think about this NIOSH hierarchy of controls, something that's higher than the individual, higher than training, and is an engineering control, but didn't exist for these nurses, and they didn't understand that. We also found this was interesting, where only one drug of interest was received by the patient, we sometimes found the other drug. And so what that started to tell us was, ooh, maybe these rooms aren't getting really well cleaned. We know that cleaning for chemotherapy is a 4-step process, and that discharge cleaning may not necessarily include all 4 of these steps to remove chemotherapy from the environment. And so perhaps some of this is remaining in these rooms in between and after patients. And so I'll talk a little bit more about a study that we have underway right now that really studies cleaning. So these are a couple of currently funded studies. So with COVID-19, I thought a couple of things happened. So the Oncology Nursing Society published interim guidelines for PPE use because of supply challenges during COVID. So they basically told us it's okay for a little while to reuse your chemotherapy gown between patients and to save it for kind of use over the whole day, because we need to be really careful about supply, and we're using our supply elsewhere. So we were curious to see if those guidelines contrasted with the increased public appreciation of the importance of PPE, changed contamination levels on these 2 units. So we received a little bit of funding and we resampled all of the same 140 surfaces that we had sampled in that first internally funded study. And we gave the same survey about PPE use, and that data is under analysis right now to see whether or not people's PPE use changed. It was sort of a natural experiment with COVID. Did people's PPE use change during COVID? And if so, did that have an impact on surface contamination levels? This is another currently funded study where we're really focusing on toilets. This is the one I was swabbing for today, where we're really focusing on toilets and we're focusing on cleaning. And so we want to understand, ONS has told us for decades actually that we should be using these plastic backed pads over the toilet in the hospital setting where we don't have a lid to minimize contamination. And they say that that's a best practice, but it's not actually backed by any scientific evidence. And so we are wondering whether or not that really makes a difference. And so we're testing 3 locations within the bathroom at 3 different time points: before the patient receives chemotherapy, during the patient's chemotherapy, and then after discharge cleaning, again, to get at that interesting piece about cleaning and whether or not the routine cleaning is actually removing the agents that we know that the patient received. And I haven't done a good job of pointing out the framework and which pieces of the research framework that I talked about at the beginning are here. So I won't say much about this. That's the study that I just described with the cleaning and the chucks. And then the last study that I will mention very briefly is one that just closed in December of 21. And this was to look at silicone wristbands as a novel measure of passive exposure. So for those of you who are familiar, and this is again a nice way that my interest in farm workers and pesticides really informs the work that I'm doing here. So for those who are familiar with the pesticide world, these silicone wristbands have been used in the field because they're able to sort of serve as chemical sinks for pesticides. They're also very successful with flame retardants and other chemicals in the environment, but they've never been used with antineoplastic drugs, which are a very different type of chemical. And so we wanted to see if wearing these wristbands was acceptable to nurses and whether or not it could detect 4 antineoplastic drugs of interest to which we knew the nurses were exposed. I will tell you that wearing the silicone wristbands was very acceptable to nurses. We had a size issue with some of these bands and them coming off during doffing of gloves and gowns, but otherwise acceptable. But we had a lot of trouble with our analysis, and we're trying to redo some of that now in a second lab. So lotions and soaps and other things like that can really interfere with some of the signal on these bands. We have a pilot currently under IRB review where we're looking to collect saliva, urine, silicone wristband, and hand wipe data. And that's to help us triangulate how well wristbands serve as a passive measure of exposure and to kind of compare it to other markers. And we would use that as preliminary data for an R01 to NIOSH. So the last thing I'll say, and I know that I've talked fast like the New York City native that I am, but I'm trying to get us through in 40 minutes and leave some time for questions, is a little bit about how I have worked to translate some of this research to practice. So I am proud of having been the nursing representative on the ONS and HOPA, which is the Hematology Oncology Pharmacists Association joint position statement on safe handling of hazardous drugs, which tells our members, both oncology nurses and oncology pharmacists, what we think is in their best interests in terms of safe handling. We did a series of Q&As for our members of the Oncology Nursing Society, and I authored a few of them, but this one specifically on toilet flushing, because I get so many questions on toilet flushing and how do I keep myself safe while flushing the toilet. I'll tell you that when I came out as an oncology nurse in 2003, the technique that I was taught was the good old flush and rush, that you flush the toilet and you rush out of the bathroom. And that is just not something that we can do or teach. We need to keep healthcare workers safer when they're exposed to chemo-contaminated excreta. I've had the opportunity to write write a safe handling chapter in the chemotherapy and immunotherapy guidelines, and I'm co-editing the next edition of the safe handling of hazardous drugs text for the Oncology Nursing Society. So it's really nice to be able to have a program of research that intersects with practice and with policy, and to try to move the needle a little bit at the same time in all of these ways. So that is it. I will open up for questions, and that's my email, just my first name dot my last name @Duke. And if we don't answer your question today, or you want to continue to correspond, I'm happy to do that. I'm gonna, I think, stop sharing because I can't see the chat any other way. Is that good, Liz? Is that okay?
Yeah.
Okay.
Perfect. You're impressive with your time.
Thank you.
That is not always the easiest thing. Congratulations. Yeah, we've got a great presentation.
Thank you.
Come back and present your results when they're ready. And then I think Will has his hand up.
Hi, thank you so much. Can you hear me okay?
I can.
Okay, great. Thank you so much on that information. It was really interesting.
Thanks.
I have a question. So I'm listening in from Wisconsin, and we have a lot of agricultural workers around this area as well. But I have a question as to how can I become more informed about the specific exposures that agriculture workers here are exposed to? Is there a database that I could refer to?
So do you mean like which specific pesticides they're exposed to?
Right, or just in general, like the agricultural workers here, what are their environmental, hazards?
So a few thoughts there. So pesticides are required, whatever pesticide has been sprayed within a particular interval is required to be posted. And that's actually a federal law that farm workers know what chemicals are, which is kind of amazing, know what pesticides have been sprayed in their environment within a particular interval. And there are also things called mandatory reentry intervals where they can't go into certain locations within a certain amount of time after something has been sprayed. But the number of pesticides that exist in the United States probably outnumbers the number of chemotherapy agents that exist in the United States. There are just so many. There are some that are crop specific. There are some that are sort of geographically specific based on the kind of pest that may be in that region or the kind of challenge that the environment may protect in that region. But I will say that we know with climate change, this is becoming an increasingly challenging problem, right? There's more pests and more pesticides in use as a result of some of these climate challenges, but that will be very specific to the crop and to the geographic location, and that will be required to be posted. In terms of what else farm workers face, like heat and ergonomic challenges, and gosh, I can think of a whole host of things. I would think going to, when you look up the Agricultural Worker Protection Standard and some of what it mandates be taught, there are links to a lot of educational resources that they recommend and that they would want people to know about and to teach farm workers about. So they may be a good resource. There's also the Migrant Clinicians Network, which has a lot of resources on their page nationally, so not specific to any state. And I'm sure I can think of other places to find some good information on what farm workers are facing in Wisconsin. So I'll do some thinking about that.
Okay, thank you so much. If there were be any way to forward that to us, that'd be fantastic.
Sure.
Thank you once again.
I'm making myself a note.
Did you want to send us your contact information, Will, in the chat, or direct message through the chat, and we can get that?
Yes, I can certainly do that. Thank you.
I see Luce's comment that there's lots of discussion about chronic low dose exposures and their impact. Yeah, and that's really where I feel like my work is centered. So I'm really worried about those of us oncology nurses and oncology nursing assistants and EVS workers who are in oncology settings who may not have large, it's not like the exposure that happens during a chemo spill, but we're doing this for an entire lifetime. And so we're going into these settings where we know this residue is on surfaces. We know that we have the chance of inhaling it when closed system transfer devices aren't used and we're administering it or taking it down or flushing the toilet. And so that's exactly what I'm concerned about as well. And I see Annie's question, have you created assessment tools from your research? What is something that you learned working with legislation? So assessment tools from your research. Tell me more about what you mean by that. If you can. Annie may be in a place where she can't. I'm not sure what she means by assessment tools. We're using an existing instrument to assess PPE use. And that's one that's been validated and used in a lot of studies with nurses to assess PPE use when working with hazardous drugs. And that goes beyond antineoplastic drugs. And those factors of influence and what predicts PPE use comes out of Pender's health promotion model. So kind of is like theoretically framed as well. And so we have adapted that tool several times with the provision of the tool developer for some of these non-nursing target audiences, but we did not create a new tool for assessing PPE use. When it comes to assessing like surface contamination, we're using a validated procedure with validated solvents and, you know, things that are already established. So we haven't created anything there either. We're probably among the few looking at or testing the silicone bands with antineoplastic drugs. But again, we're working with people who have used these bands in other contexts and other settings. Oh no, that's okay, Annie, she's at work. And then something that I learned working with legislation, gosh, I learned a lot of things. I guess one thing that I didn't really understand until I experienced it myself is just how powerful the nursing lobby is and like how many people we really represent. So when I got called to Raleigh to work on this legislation, and I kept saying to them, I don't think I'm the right person. I'm not giving these drugs anymore. What I realized was that I was a constituent, right, of the North Carolina Nurses Association, which has, I don't know, I'm not going to hazard a guess on how many members they have, but a lot. And then also I was a member of the Oncology Nursing Society, which is nationally a really big professional organization. And so what was important was that once I got those letters of support, they weren't the voice of one nurse. They were the voice of thousands of nurses because this professional nursing organization signed on and said, we back this and we believe that it's important. And so I think being closely tied into your professional organizations, knowing who your lobbyists are, knowing who the leaders are within your professional organizations and feeling comfortable to make that ask and say, can I have a letter of support or would you help us get support for this legislation was really crucial. And so I would say before you need something, be politically active within your professional organization so that you're known to the leadership and the membership so that when it comes your time to make an ask, you really can get the voices of many and have the backing of many. Sure, you're welcome. And Will, I'm writing down your email before this goes away. Okay.
My question was your work with different labs. You know, it's difficult. Is it difficult to establish those relationships or pick from a variety, or are you just kind of limited to one?
Yeah, that's a good question. So it took me a while when I first came to Duke to find my people and find my way around and establish a research team. And so I joked with my husband that I felt like every time I came to work, I was going on a date, because I would just ask people who had similar interests that I found on the website if I could talk to them about my program of research and if they knew of anyone that might be helpful to connect with. And so 2 or 3 times I got the name of this one analytical chemist who runs our pharmacokinetics, and now called investigational chemotherapy lab. And I realized after I had heard his name several times that he was an author on several of the studies that I read. And so when I contacted him and said, look, this is what I'm looking to do. Do you do trace analysis work like this? He said, well, I have in the past, but it's not the lion's share of what we do. And so you would kind of need your own instruments that are super clean and could be used for trace analysis, because we're used to testing like doses that patients receive of chemotherapy, and you're looking for stuff that's like really trace. And so our stuff is kind of contaminated. So I used a lot of my startup money and, early pilot funding to buy my own equipment for that lab. And so now I feel like I have my own little teeny tiny, I don't know how much space my equipment takes up, maybe a foot of space in someone else's lab. But it was also establishing good rapport with him. And now he's worked on 5 or so studies with that 4, I know, because we labeled samples today and we have them specially labeled in his freezer. So he's worked on 4 studies with us. And as we put in some of these bigger studies and these R-level studies, he's named as a co-investigator, because he's not only done the analysis, but really helped us to understand and interpret the results. I'm moving more and more to a new collaboration as well with someone in our Nicholas School for the Environment, who's done a lot of the silicone wristband work, not only here at Duke, but nationally, with flame retardants. And so as I'm moving into a new way of assessing this exposure, her expertise is, paramount. And so we're going to be running some things with her that we have not run before. So now it's a little work, definitely not space, not equipment, but a little work with another investigator as well, who has expertise in the place where we're trying to go. And is interdisciplinary, right? Like these are chemists, which I am clearly not.
The nurse and chemistry, we have an interesting relationship for sure.
Yeah. And they are not clinicians. So that's kind of where I bring my expertise, right? Like, how is this really going to work in the clinical setting? How are we going to get that urine? How are we, what happens when the nurse is wearing the band? And even thinking about like doffing and wristbands coming off during doffing of gowns, that's not something that people who do community-based work with kids necessarily come into contact with, right? Like they just keep their band on all the time. It's not this on and off of PPE throughout the workday.
Yeah, unfortunately, I think if you've worked in the hospital setting, I think nurses that have worked in the cancer units or wards or whatever, and it seems more times than not that they're the ones that get cancer. You learn later that, and it always ends up being those same nurses that have worked on those wards. So this is really, really important stuff. I'm so glad.
Thank you. I want to be clear to not overstate it. We can't say with certainty that, we don't have really good longitudinal data that says that these exposures are why nurses get cancer and later in life. If we did, I think we could get a lot more done in this arena, but naturally exposure happens everywhere, right? In your environment, there's lifestyle factors, there's all these other things that go into whether or not someone gets cancer. But one thing that we do know for sure is that nurses have shown translocations in chromosomes 5 and 7. Nurses who have administered these drugs or been exposed to these drugs, low dose, long term. And those translocations in chromosomes mirror MDS, myelodysplastic syndrome, which is a precursor for the acute leukemias. And so, we do have some biological proof that there's reason for concern about these exposures. And that's where I think we need some more science and to get people really, we've known that this is a problem since the 1970s and policy has been slow to change. So I think we really have to show the data that nursing assistants, EVS workers, even unit secretaries. There was a study that came out of Canada that showed that of all the types of workers on a unit, those who had the highest urine metabolites for these drugs were the secretaries, who weren't actually even in the patient rooms. And they concluded that it was probably because the nurses were using their contaminated PPE to come out into these shared work environments, where unit secretaries practiced with no PPE. And I can think about my own practice, answering the phone on a busy day with my chemo gloves on or my, chemo gown on, just trying to be helpful and not really thinking about my role in creating a safe community and creating a clean community for everyone who worked there, including people who didn't have the same level of education and training as I did about these drugs. So I think we have like shared responsibility for our environment and keeping our environment with the lowest levels of contamination that we possibly can for all workers.
Great, Dr. Walton, thank you so much. Do we have any last minute questions? We appreciate everyone coming. Thank you again. And
Thank you.
see you
Thank you for having me. Go ahead and get started, Liz.
Yeah, I'll introduce you real quick and
Okay.
you can take the floor. My name is Liz Mazzell. I am the co-chair of A&E's research work group. So